Good evening, good morning, good afternoon, everybody. It is 6 p.m. in Paris, 6 p.m. in Rotterdam, 7 p.m. in Jerusalem, and noon, I think, in New York. And it is my great pleasure to welcome you all to this new Journal Club broadcast brought to you by the International Academy for Clinical Hematology. I'm Mohamad Mohty from the Sorbonne University and Saint-Antoine Hospital in Paris, in France. And it's always a true delight to moderate this journal club, which is now celebrating more than 2 years, and it's proving to be extremely popular. As you may have noticed, we had our summer break during August, and this is now our first journal club for starting this season. And these are the usual acknowledgement to all the supporters of the ICH. Thank you for your generosity. These are unrestricted educational grants, and commercial companies do not interfere with the scientific content or the planning. So the steering committee decided or chose this recently published article in the Journal of Clinical Oncology by Versluis and colleagues on behalf of the Blood and Marrow Transplant Clinical Trials Network. And the title is Allogeneic Hematopoietic Cell Transplantation Improves Outcome in Myelodysplastic Syndrome Across High-Risk Genetic Subgroups. Genetic Analysis of the Blood and Marrow Transplant Clinical Trials Network 1102 study. And we're very fortunate and honored having with us today Dr. Jurjen Versluis, who is a consultant hematologist in Rotterdam, deputy director of the BMT program there. And he has contributed a lot to the field of transplant and myeloid malignancies, following on the path of Professor Cornelissen, Professor Bob Lowenberg, and all of these fantastic masters. And our second faculty today to discuss this paper is the ICH co-chair himself, Professor Arnon Nagler, whom I don't need to introduce, a master in the field of transplant, and he will be here to give, I would say, the non-co-author voice. So you can see here the abstract of this work. This was about sequencing 309 patients which were included in a prospective trial in the US, and the goal was to assess the association of the different gene mutations with outcome, namely overall survival, with a special focus on the impact of TP53 mutations and whether transplant could be of benefit in this subgroup. And to make a long story short, well, first, transplant is doing better than no transplant, although this is not randomized. It's a biological assignment, donor versus no donor. But most importantly, and I think this has been an important message from this paper, is that although the outcome of patient with TP53 mutation is very dismal in general, and this is really horrible news, they still benefit actually from the immune GVL effect after allotransplant. And obviously, one of the questions we will debate with the panelists in how we can further improve the outcome of these patients. So you can see the design of the study. The clinical trial included 384 patients. They had samples was 309 229 were assigned to the donor arm, 80 didn't have a donor, and the investigators did a great job doing the genetic analysis. And you can see here the multivariable analysis and the hazard for death, looking, for instance, into some of these mutations, TP53, DDX41, KM2A PTD, the karyotype, gender, duration of the disease, the IPSS score, age above or below 65, ECOG score, but also the Karnofsky score. And you can appreciate, I don't need to explain this forest plot, which is very straightforward to understand. Another, I would say, very meaningful finding, which has reached the statistical significance, although one must acknowledge that this wasn't the primary goal of the study, but it is important to see in the subgroup of TP53 mutations. You may argue about the numbers, but still there is a clear benefit. This is a blue curve for transplant versus no transplant. So I'll stop here and we'll start the discussion with our panelists. And as usual, the first question always goes to our non-co-author guest. Here it's Professor Nagler, to get his thoughts when he has seen this paper. And by the way, the Journal Club is always brought live to you, so you can always send and share your questions, your comments, and I'll do my best to discuss them and share them with the panel. So Professor Nagler, first of all, thank you for joining. I hope everybody enjoyed the summertime and had some good holidays. At least you look very bright and cheerful. So what are your thoughts about this paper?
So thank you, Professor Mohty. First, I would like to congratulate Jurjen, Dr. Versluis, for this important paper. So first, the paper is based on an important clinical trial of the BMT-CTN 1102 that showed with natural randomization the advantage of allogeneic transplantation for MDS, which was not nailed down before. So the clinical study by himself is important. And then, of course, in the new era of hematology, everything is based on mutation. So deep sequencing and mutation analysis is very important. And as Jurjen stated in the paper, till now there was no comparison of patients with mutation that undergo transplant to no transplant. So we have here two-arm study in patients that we know their mutation, showing the benefit of transplant, including in the new classification of MDS, IPSS-M, high and very high risk, which is important by itself, and also in patients with P53. And as you alluded to, every lecture that we give on MDS, somebody is asking, should we transplant a patient with P53 MDS or AML because the results are so bad? So it's extremely important to see the advantage of transplantation, although this is not home run, and although patients with P53 still do worse than patients with no P53. Also interesting is the question of the monoallele to the B allele, and here, a bit surprisingly, the overall survival of patients that underwent transplant, the B allele or monoallele, is the same, and this may be also important. So I think that this is a very important up-to-date paper that nailing or proving the benefit of allogeneic transplant to high-risk MDS, including the one with P53 mutation.
Thank you very much, Professor Nagler, for these positive comments, and I fully agree, and I'd like to congratulate Jurjen for really leading this effort. So Jurjen, the question for you now is to give us a little bit of context about the rationale and why you did why you decided to do this work. Obviously, Professor Nagler highlighted that we live at the era of molecular biology, and you have to correlate everything with molecular data. But still, you know, the original clinical trial was quite convincing and conclusive. So give us a little bit of context, and what is the value of these mutations in MDS?
Yes. Yeah, thank you for having me in this journal club, Professor Nagler and Mohty. So when talking about the rationale for this analysis, we need also briefly to touch base on the rationale for the 1102 study itself. Because when the study was designed in the US, early transplantation for older individuals with MDS was not broadly accepted. And therefore, the investigators designed this biological assignment trial, including patients between 50 to 75 years of age with IPSS intermediate 2 or high risk disease who were eligible for transplant. And the results, as you said, were published in 2021, also in JCO, by Ryo Nakamura as the first author and Corey Cutler as last author, which clearly showed that survival was improved for patients with an available donor compared to those without. But like you said, next generation sequencing mutation analysis was not available in this part of the trial. So we were able to get the samples for 309 patients who were enrolled in this trial to do the sequencing and really looking for these findings in the trial, whether these were consistent across the genetic alterations found in MDS. So do you recommend actually, based on these data, to perform NGS and looking for all of these mutations in MDS? Well, especially in this high risk subgroup of MDS, I guess most physicians, most hematologists will try to proceed to transplant if there's a donor available and the patient is eligible. But still, as you might have seen in the paper, there are differences in outcome if you look, for instance, at the most frequent mutation, TP53, but also if you look at the IPSS-M, the molecular IPSS, where you will see that also in this transplant cohort, there's differential outcome with the increasing risk groups of the IPSS-M. So yes, I think it really might help to select your patient and counsel your patient for outcomes with the allogeneic transplant. Okay.
I would even say that, you know, as the results are not home run with the P53, it's important to know the mutation because of the possibility to do something pre-transplant for this patient, and also after transplant, like magrolimab, although the study in MDS was just stopped, you know, by the FDA because of futility, still, you know, for patients with high-risk mutation, you may want to give venetoclax, or as Jurjen discussed in the paper, you know, the suppressive microenvironment, maybe to do something with the environment. So we need to know these days the mutation for targeted therapy pre and post-transplant. So it's not just I would say the prognosis of the outcome of the transplantation is different, but also we should address patient with mutation if we can.
Thank you, Professor Nagler. So that brings me actually to ask you, Jurgen, more specifically about the TP53 mutation, because when we look into the literature, there is a lot of controversy about TP53 allelic state, the VAF, the conjunction with complex karyotype, whether there is a mutation clearance prior to transplant. But apparently here, all of the TP53 mutations go in the same bag and are of dismal impact. Is my interpretation correct, and how would you handle this?
Yes, so that's a great question. I'm, as you know, a bit more positive than saying the word dismal. But we know from literature, and that's also what we observed here, that the outcomes of patients with TP53 mutated MDS are still poor. And we're still looking here at a 25% 3-year overall survival with transplant. But as we showed in this study, and that's what previous studies were not able to show, that with a non-transplant comparator, a transplant is actually associated with significantly better outcome compared to the non-transplant approach. And you're right that the allelic state might actually be something influencing outcome. But when we performed the multivariable analysis, which you showed on the slide, we saw that for overall survival, the multi-hit state was actually associated with a slightly higher hazard for death, but not as bad as we thought it would be. So we really feel that the allelic state in this high-risk MDS cohort is not as important as it has been previously published in a more broader subgroup or more MDS group, which also included lower-risk MDS subgroups, and those might actually have a more pronounced impact of the multi-hit TP53 status.
Excellent, thank you. Yeah, please.
Yeah, so you also asked about the mutational clearance. So that was actually also a great point, which we also were able to address because these samples were obtained at the day of randomization or close to randomization. And patients still had to wait until the transplant was performed, which was typically 3 to 4 months, if I remember correctly. So we were also able to acquire samples from patients very close to the actual transplant date. It was 35 patients. And we found that in those 35 patients, mutations were still present in 33 patients. So only two patients somehow cleared their mutations. And it has been suggested that survival could be impacted if your VAF reduces below a certain value, like 5%, maybe 2%. So we also used that cutoff when we resequenced those samples and found actually also no impact on overall survival with the different thresholds. So mutational clearance with some therapy until transplant was also not associated with better outcome, really suggesting that these patients did relatively well, acknowledging that it's still 25% and we need to do better. But those patients really did well because of the transplant.
Excellent, thank you very much. And you have elegantly alluded to the fact that despite the benefit of allo in this TP53 mutated group, this benefit remains a little bit modest. And I think this is acknowledged in the discussion of the paper. And that brings me to 2 remarks and questions by Professor Ganser from Germany, whom I say hello, about the role of pre-transplant treatment and post-transplant maintenance. I guess in this protocol, maybe things were not standardized, but in general, Professor Nagler, what are your thoughts about how to manage these patients before and after transplant? Because sometimes in MDS, some recommendations are about, okay, don't treat and just proceed to transplant, whereas we know today that hypomethylating agent, but also some novel drugs like luspatercept, we mentioned venetoclax, are feasible in MDS. I'm not saying they should be done, but definitely there are more and more options. It's not the era only of transfusion in MDS.
Yeah, I would agree that, I think that studies about chemotherapy versus ciprovidaza or going straight to transplant are, maybe revisit now that we have more than targeted therapy. MRD is becoming very important in AML. In MDS, it's more difficult, I would say. But you know, it's logic that if you get a patient with negative MRD or low tumor burden to transplant, especially that in this group of patients, you can use only reduced intensity therapy. So I think that modern targeted therapy pre-transplant, maybe we need to study it. I mean, intuitively, I would say that it will be, I mean, logic to give it. And also post-transplant, as you say, although the studies with Vidaza are not, you know, not everybody agree, but for sure, in this high-risk group of patients, we need to give some kind of maintenance therapy post-transplant. So I would say that this is part of the combination of the package of the transplant today, to my opinion.
So thank you, Professor Nagler. Jurgen, today in your practice, you have a high-risk MDS with TP53 mutation. How would you manage this patient? Practical recipe from Rotterdam.
Yes, so excellent question. And I think with an MDS, we would try to get a donor as fast as possible. And if we are able to obtain a donor, we would proceed to transplant. But if the MDS has an increased blast count for, let's say, above 10%, we would prefer some intermediate treatment with azacitidine, for instance. We typically don't give venetoclax to these, especially to the TP53 mutated patients, because we don't believe in the efficacy in that subgroup. And in Rotterdam, we don't have access to the new drugs like magrolimab or eprinepatop, who might also be actually very feasible in these high-risk MDS patients.
So, Professor Nagler, there was some historical data suggesting that actually one explanation why allo works in the TP53 mutated, I would say, myeloid malignancies, that there is a sort of an immune privilege or whatever, immune sensitivity. So does this provide a rationale, for instance, for using some of these immune modulating agents or immune checkpoints or interferon gamma driven transcriptional program to boost the GVL effect? This is a comment and question we have from Daniele Avenoso from London. Hello, Daniele.
I'm not sure. I mean, of course, I mean, the transplant, the work against this high mutation is because of the GVL effect, and so it's immune effect. And of course, this, I mean, as in this paper and as all of the papers show that it's not strong enough and we need to boost it, because the results in P53 are still worse than, you know, the patients that don't have P53. I don't think that the studies with interferon upregulating HLA and those kind of study, you know, was too successful. So I mean, I think that the field is waiting for something more innovative in order, you know, to boost or the graft versus leukemia effect. I would not say, I would not go back to the interferon, because these studies were done. Also, this is a crude way. There is a risk also for graft versus host disease in this elderly patient. So I'm not too excited about this, but yes, I mean, if there will be a way to checkpoint inhibitors also were not too successful in AML and MDS, unfortunately. So we are all looking for the you know, miracle drug that will help these patients, I would say.
We have one question, Jurgen, about prophylactic DLI. Is this something you would practice commonly?
Yeah, that's absolutely something you could consider especially in the TP53 mutated MDS, actually to just exploit the alloreactivity and try to get the donor as ready as possible to attack the residual disease. So yes, I think especially in Rotterdam, we do that quite often to perform DLI in these patients. The difficulty is you don't have a true marker to define your strategy to be on. So we'll try to do it in a prophylactic way in these high-risk patients, and also try to taper immune suppression as soon as possible at first, and then after that consider DLI, especially in the TP53 mutated MDS. Yes.
Excellent. And we have a comment from Professor Ganser. So we have the Hanover recipe from Germany, where he definitely agrees with you not to give venetoclax in addition to azacitidine in TP53 mutation. I think this is an important piece of advice. So one question to you, Professor Nagler, because you have transplanted hundreds, if not thousands, of these patients over the last 35 or 40 years. Assuming we have a donor, we go to transplant, are there any specific issues or parameters one needs to take into account when offering transplant for these patients, when it comes to conditioning regimens, when it comes to GVHD prophylaxis? We mentioned, you already, both of you alluded to DLI and decreasing immunosuppression rapidly. Any other tricks to improve the outcome of these patients?
So for sure, we give this patient only reduced intensity. I would say that today, with most of the patients being unrelated, we are moving to the PTCY, and this drastically reduces the transplant-related mortality and also chronic GVHD. As I always say, in this elderly population, the problem is if they get GVHD, the chance that they will, can recover the GVHD. So the body reserve is very low. So if we can eliminate GVHD, it's extremely important, because once this elderly patient get complicated by GVHD, as opposed to young patients, they usually don't survive the GVHD. PTCY will be important. DLI, yes, we are giving to some of the patients, and we give Vidaza. I mean, there is controversial data about combining Vidaza and DLI, if it helps or not, but as all, we are using this. I don't think that we have any other secret or recipe, that for these patients.
No magic recipe, but lots of good wisdom. So, Jurgen, you have a question here from Dr. Jorge Oliveros Alvear. Thank you for joining us. And he's asking you, in a 64-year-old patient with secondary MDS, secondary to chemo, this patient has 3.4% blast. Would you recommend giving azacitidine prior to transplant? The donor is immediately available, assuming this, or should you proceed to allotransplant immediately?
Given that this is a high-risk MDS patient, yes, then we would try to transplant that patient as soon as possible. That's something I would recommend. So,
excellent.
If I may allude to or add to what Arnon already mentioned, we really need studies for these patients, especially when talking about maintenance. The TP53 mutated MDS subset of MDS still sees a poor outcome, and we need to improve that. And I'm really hoping that the studies with magrolimab in the TP53 mutated setting would add to improve the outcomes in this difficult to treat population.
So we'll talk about future studies, but before talking about, because that's going to be about our conclusion, we've been talking now for the last 30 minutes or so about the bad mutation. And here I would like to mention the good one. It's relatively rare, the DDX41 mutation, 7% of these patients. But these patients have usually favorable outcome, relatively low risk of relapse. And actually, this is not very controversial. It has been confirmed through different studies. So the question is, given that this is a good risk parameter, for me, it's a double-edged sword. Should they go to transplant or not? Because if they go to transplant, they do very well. They have a low rate of relapse. But on the other hand, they're not, I would say, bad. They're not a bad subgroup. So why taking the risk of transplant? I know there's no right or wrong answer. What's your feeling about it?
Oh, so that's a great comment, and that's a difficulty in this study because only 3 patients were treated without a transplant, and actually 20 were transplanted who indeed had favorable outcomes. The issue still here is that we're looking at an IPSS intermediate 2 and a high-risk MDS cohort. So these patients, apart from their DDX41 mutation, had also increased blast counts, low blood counts, cytopenias, and therefore had a high-risk disease. And given the high-risk MDS, with the DDX41 mutation, they had these favorable outcomes. So it's difficult to say that not transplanting these patients would also serve them well. But what we saw in this paper, that actually only 1 patient relapsed, and that patient also had a TP53 mutation. And the others who died of non-relapse mortality. So I fully agree with you, Professor Mohty, that this population of relatively favorable patients need the emphasis on reducing toxicity to reduce transplant-related mortality and issues. Talking about conditioning, low HTTCI score, and really talk to these patients considering not to transplant when it's not really needed.
So before reaching the conclusion, and for the sake of clarity, we have a comment and a question from Dr. Mike Radford about what do you mean, guys, because both of you use the same wording, early tapering of immunosuppression. Is it 2 months? Is it 1 month? Is it 3 months? Is it 4 months? And I think the comment is very fair and well taken. Thank you, Mike.
I let Professor Nagler answer first.
No, I mean, this is why I always say that medicine and transplanter is not mathematics, but art. So, rapid tapering, all of us that transplanted for more than 1 year know that he had in his life a patient in which he reduced cyclosporine by 5 milligrams, and the patient developed grade 4 GVHD and died within 24 hours. And so we had this patient on in our career. So I would say that this is art, and it's dependent on the patient and how you feel the patient. And I don't have the recipe. What you mean? What does it mean? Early reduction. We always say it, and even wrote it in our recommendation paper on behalf of the Acute Leukemia Working Party. But it's very slowly and very gradually. I mean, I omit that I cannot give the dates or the, more than that.
I like this answer, Arnon, and I feel reassured that we will not have soon an iPhone or a smartphone app telling us exactly how to do things. And I like the idea, the concept of the art of transplant. And this is about clinical judgment. But I believe, guys, you would agree with me that usually the semantic, when we in the transplant field talk about early tapering, we're talking something around between 2 and 4 months, depending on the status of the patient. I hope Mike is happy with this comment. Okay, now it's almost the end of this webinar and journal club, and Remember, we started the first question with Professor Nagler, who didn't contribute to the study. Now, the final question and conclusion is for you, Jurgen. So you did this fantastic work. Again, congratulations, JCO paper. What is the next step? What are you currently doing, or what are you planning to do to move this field forward? Because my best guess is that until we cure all of these patients, we still have a lot to do.
Yes, so that's not an easy question, Mohamad.
I'm not supposed here to ask easy questions, Jurgen. My role is to be the devil advocate.
I like it. Like I said, we need studies, especially for the TP53 mutated disease. We didn't talk too much about the very high-risk IPSS-M subgroup, but we saw really good outcomes in that population. So I really believe that we need to improve outcomes of TP53 mutated MDS. And I find it difficult to say what's the best approach. Do we need better pre-transplant treatments, inducing better disease control? Do we need to improve our conditioning regimens for these patients? I think we know that myeloablative conditioning regimens for these patients is not really beneficial. And I personally more believe in the post-transplant interventions aiming to mitigate the risk of relapse, for instance, with maintenance therapy, with azacitidine, with one of the novel drugs like eprinepatide, magrolimab, or if you don't have access to those kind of treatments or studies, maybe prophylactic BLI. Of course, first early tapering of immune suppression and then prophylactic BLI.
Work in progress, but definitely a lot of hope for these patients. And I do remember 30 years ago at medical school, the MDS chapter for us, I don't know for you guys, but was like 3-4 lines saying it's a disease of the elderly and you can do transfusion. It's quite incredible now that we are really dissecting these molecular entities, and hopefully within the next few months and years, we will continue to cure more patients. I do apologize. We have reached the end of this journal club. I do apologize for the colleagues who sent many very specific questions, how to handle this and this, but I'm sure you can reach out to Dr. Versluis and to Dr. Nagler. And I do apologize because I mentioned earlier that Professor Ganser is in Hanover. He used to work in Hanover, but he's now retired in Frankfurt, by the way. So apologies, Arnold. So I hope everybody has enjoyed this journal club. Thank you for being loyal to the ICH activities. I do kindly remind you that next week on the 11th of September, we have a special broadcast about standing on the shoulders of the giants. And you may have seen the announcement. This is a fantastic interview with Professor Alan Fisher, the father of gene therapy in immune deficiencies. You will love it. We have our usual weekly podcast. And you may have enjoyed this week. Actually, it was by pure chance. This week, we sent the broadcast about the approval of luspatercept in MDS. And that was a fantastic summary made by Professor Uwe Platzbecker from Leipzig in Germany. Thank you, Uwe, for contributing. And please don't forget to contribute to the ICH activities. For instance, you have the Junior Club. This is for our young colleagues. Please don't hesitate to submit your clinical cases, your case reports to be discussed within the Junior Club. I do remind you kindly that on the 5th, 6th, and 7th of October, we have our annual physical meeting in Paris with 4 tracks, actually, the transplant track, the leukemia track, the MPN track, and the lymphoma track. So with this in mind, thank you very much. Thank you again for joining the ICH activities, and wherever you are, hope to see you soon. And please stay safe and keep well. Thank you very much.
Thank you.
You.